Okay, good evening, and I welcome you all to Yashoda High Tech. So, yeah, the it's a burning topic now, whether SAVR or tower. Anyway, now the topic is that today we discuss about the low risk, maybe intermediate risk as well. Okay, so as we all know, calcific aortic stenosis is most common acquired heart valve disease, and this is the timeline, the natural course of these aortic stenosis patients. Once they start having symptoms, and majority they do not last more than 5 years. So for decades, surgical valve replacement was the treatment of choice, and I still remember when I was doing my MCH at AIMS, lot patients who were inoperable with multiple complications, especially lung disease or the radiated chest. So these patients, our professors, they used to decline and then put them on medical management. So I think they estimated worldwide there were like in huge numbers these rejected patients for surgical valve replacement. So this led to development. I am sure these cardiologists, they jump anywhere where there's an opportunity. So they started developing these catheter-based solutions and started with balloon aortic valvoplasty, similar to the pediatric one. And then Dr. Alan Cribrier, he developed this TAVI in 2002, and that changed entire landscape. The cardiologists had another weapon in their hands, and they started doing these cases, and this is a 20-year journey, and from 2002 to now, and it involved multiple studies to substantiate the benefit of tower in to start with high-risk patients, then to intermediate, and now to low-risk patients. So these we'll go through the guidelines, and these are we all know the symptomatic aortic stenosis with I gradient is definitely valve replacement, and the low flow, low gradient, the paradoxical is they're also like aortic valve replacement, and asymptomatic is one which is always under discussion, but there are clear-cut guidelines now whether the patient requires aortic valve replacement or not. And these are the recommendations from AHA. So the aortic stenosis symptoms, if they are symptomatic and severe aortic stenosis in stage D1, then clear-cut aortic valve replacement, the patient is fit, or TAVI, if the patient is unfit. And the stage D2, D3, they're all there for aortic valve replacement. But without no symptomatic aortic stenosis patients with BNP, just the BNP 3 times elevated, and there is a Vmax of more than 5. There's a SAVR which comes under level 2. So for this program to develop, obviously there has to be a heart team integration, and there has to be a proper discussion between the cardiologists, surgeons. I don't know whether it's happening, but and the anesthetists, and the people involved in this program development. So if you look at the choice of SAVR versus TAVI, okay, so these adult patients with aortic stenosis, so if they do the risk assessment, and if the risk is not high or probative, then you classify whether the patient is young, then go for a mechanical valve, or in some cases Ross replacement is the patient is very young, and more than 65, then the question of bioprosthetic comes in, or in a patient who's not for oral anticoagulation. Then once the bioprosthetic, then you divide the patients into the less than 65, 65 to 80, and more than 80. So TAVI in more than 80 is almost now clear cut, and it's now pulled down to 75 as well. So definitely they do well, because if you take the Indian life expectancy at 75 and above, then the tower valve should last their life. So they are okay, but the gray area zone, 65 to 80, is always is a area where we all can have discussion, and the patient interest has to be kept in mind to do. And the low risk is another area where the SAVR does very well actually. So this is the same, the chart. So below 65, SAVR is recommended with the life expectancy is more than 20 and more than 80. Now it's 75 possibly at least in our sittings.